Hey guys, this is Fixer Med. Welcome back to my high yield anatomy review series for the USMLE Step 1, NBME CBSE, and NBME CAS examinations. In this series, I will be covering a broad overview of the discipline of anatomy across various organ blocks for these examinations. This will be part 56 of my multi-part video series of doing so. Without any further delay, let's go ahead and get started on today's content. Let's start off by taking a look at lymphatic drainage from facial structures. Submandibular lymph nodes receive lymph from front of scalp, nose and adjacent cheek, upper lip and lower lip, except the central part asterisk, frontal, maxillary, and ethmoid air sinuses, upper and lower teeth, except lower incisors asterisk, anterior 2/3 of the tongue, except the tip asterisk, floor of the mouth, gums, and vestibule. Note, lymph from the excluded areas drains to the submental lymph nodes. Let's next take a look at blowout fracture. A blowout fracture of the orbital floor typically does not involve the orbital rim and is caused by blunt trauma to the orbital contents, for example, by a handball. Blowout fractures may damage the inferior rectus muscle, an infraorbital nerve and artery, leading to hemorrhage. These fractures are rare in young children because their maxillary sinus is small and the orbital floor is not a weak point. Let's next take a look at muscles of the orbit. I will list each muscle, followed by its action, then follow it up with its innervation. Superior rectus elevates and adducts pupil. Cranial nerve. 3. Inferior rectus depresses and adducts pupil. Cranial nerve 3 medial rectus adducts pupil. Cranial nerve 3 lateral rectus abducts pupil. Cranial nerve 6. Superior oblique depresses and abducts pupil. Cranial nerve 4. Inferior oblique elevates and abducts pupil. Cranial nerve 3. Levator palpebrae superioris elevates upper eyelid. Cranial nerve 3. All right, guys, now that we have covered all of the content, let's go ahead and take a look at some questions to review the knowledge you have gained so far. A 45-year-old man presents with a painless, progressively enlarging mass under his jaw. On examination, a firm, non-tender lymph node is palpable in the submandibular region. The patient has a history of chronic sinusitis and recent dental work involving multiple upper teeth. Which of the following structures is most likely draining lymph into the enlarged submandibular lymph node? All right, I think I gave you guys enough time here. I'm going to move on to see what the correct answer is and what the reasoning behind it is. If you need more time, feel free to pause the video. Otherwise, moving on now. The correct answer is D, maxillary air sinuses. The submandibular lymph nodes receive lymph from several structures, including the frontal, maxillary, and ethmoid air sinuses. Chronic sinusitis, particularly involving the maxillary sinuses, can lead to enlargement of these lymph nodes due to persistent inflammation and drainage of infectious material. All right, let's go ahead and see why the other answer choices are incorrect. The incorrect choices can be explained as follows. A. The tip of the tongue drains lymph to the submental lymph nodes, not the submandibular lymph nodes. B. The central part of the lower lip also drains to the submental lymph nodes. C. The lower incisors lymph drainage goes to the submental lymph nodes rather than the submandibular lymph nodes. E. The skin of the mandibular angle drains into the parotid or submental lymph nodes, not the submandibular lymph nodes. All right, now that we have covered this question, let's move on to look at the next question. A 25-year-old man is brought to the emergency department after being struck in the face with a baseball. He complains of double vision and numbness over his right cheek. On physical examination, he has limited upward gaze in the right eye and decreased sensation in the infraorbital region. Which of the following structures is most likely damaged? All right, I think I gave you guys enough time here. I'm going to move on to see what the correct answer is and what the reasoning behind it is. If you need more time, feel free to pause the video. Otherwise, moving on now. The correct answer is B, infraorbital nerve. The infraorbital nerve is commonly damaged in blowout fractures of the orbital floor, leading to numbness in the cheek, upper lip, and upper gum. This type of fracture can also entrap the inferior rectus muscle, causing limited upward gaze. But the primary symptom described here is the numbness over the cheek, indicating infraorbital nerve involvement. All right, let's go ahead and see why the other answer choices are incorrect. The incorrect choices can be explained as follows. A. The superior rectus muscle elevates the eye and is not typically affected in blowout fractures, which more commonly involve the inferior rectus muscle. C. The optic nerve is deeper and would lead to vision loss, rather than numbness in the infraorbital region and limited eye movement. D. The medial rectus muscle is responsible for adducting the eye and is not typically involved in orbital floor fractures. E. The zygomatic bone is not directly involved in the symptoms of infraorbital nerve damage or the limited upward gaze described in this scenario. All right, now that we have covered this question, let's move on to look at the next question. A 34-year-old woman presents with difficulty moving her right eye and double vision. On examination, she is unable to elevate her right eye when attempting to look outward, and her right eye appears to be slightly deviated downward when looking straight ahead. There is no ptosis or pupil involvement. Which of the following muscles is most likely affected? All right, I think I gave you guys enough time here. I'm going to move on to see what the correct answer is and what the reasoning behind it is. If you need more time, feel free to pause the video. Otherwise, moving on now. The correct answer is D, inferior oblique. The inferior oblique muscle is responsible for elevating the eye when it is adducted and abducting it when it is elevated. The patient's inability to elevate the right eye when looking outward in the downward deviation of the eye suggests dysfunction of the inferior oblique muscle. Since there is no ptosis or pupil involvement, this indicates that the problem is isolated to the inferior oblique and not due to a broader issue with the oculomotor nerve or cranial nerve 3. All right, let's go ahead and see why the other answer choices are incorrect. The incorrect choices can be explained as follows. A. The superior rectus elevates the eye and adducts it, but it would cause difficulty with upward gaze in the adducted position, not abducted. B. The inferior rectus depresses the eye and adducts it, so damage here would result in problems with downward gaze, not upward. C. The superior oblique depresses and abducts the eye. Impairment would cause issues with looking down and in, not up and out. E. The medial rectus adducts the eye. Its dysfunction would cause problems with moving the eye inward, not with elevation or abduction. All right, guys, that is all I have for the video today. As always, be sure to leave a like and subscribe to the channel for more videos like this if they are beneficial to you. If you have any questions, comments, or concerns, please feel free to type them up in the comment section below. Anyways, guys, this is FixerMed signing off. Be sure to have a great day, everyone. Good luck studying as always, and goodbye.